Greetings. Today we are going to discuss regarding the timing of vaccination. When is it right in clinical practice? Hi, I'm Dr. Neha Gupta, infectious diseases specialist, and I'm founder of NG Swasta and secretary of SIDS India. So I'll begin with this case. This is a 47-year-old lady with cardiac uh, transplantation, and she was on immunosuppression. She was on prednisolone, MMF, and tacrolimus, and she was doing good for a few months until she developed this acute onset breathlessness and pneumonia. And she had to be admitted in the ICU with invasive ventilation and required inotropes as well. She was started on broad spectrum antibiotics, which included meropenem and colistin. She improved, however. The inpatient hospital stay was almost 20 days, and this definitely added to the morbidity as well as the healthcare cost. Do you know what was the cause of this pneumonia, which is a community acquired pneumonia, as it happened more than a few months later after the cardiac transplant? So this fulminant infection was because of the Streptococcus pneumoniae, which is a bacteria, and it can be prevented with effective vaccination. Another lady who had presented with the severe pain, and she consulted to us because of the severe neuralgia. She also had secondary bacterial infections, and we treated her telephonically through the video consultation. Now, a few weeks later, the son who was taking care of this lady presented with this rashes. Yes, he developed chickenpox. So this was chickenpox in a susceptible adult vis-a-vis primary infection in the healthy son who was taking care of his mother suffering from shingles. So many a times it's important to remember that timing of vaccination is important for the patient as well as for the caregivers to provide effective protection to the entire family. So timing matters. Even in Operation Sindoor, we saw that the success was not just related to the precision, but also the time of the strike matters. Similarly, even in vaccination, timing matters. To maximize the vaccine efficacy, it has to be done before the patient develops immunosuppression and should be done at a time when the likely immune response is the most robust. Timing is also important to minimize the missed opportunities. So when a patient is suffering, is improving, is now clinically stable, that's the best time to vaccinate and offer vaccination for further future protection. And also, the timing has to be right to minimize any adverse events. For example, in a patient who is immunocompromised, live vaccines should not be given. So, a young lady who is likely to become pregnant should be given the live vaccinations earlier. And similarly, immunocompromised patients who are likely to go in for transplantation or some immunosuppression, they should receive the vaccination prior. So the general principles of the timing of vaccination would include that it's important to vaccinate early rather than late before the patient becomes immunosuppressed, and the best time to vaccinate is the time when the body is able to elicit a robust immune response. Second principle, that when a patient is stable, vaccinate. If a patient has had pneumonia, is admitted, but when the patient is getting discharged, vaccinate. Offer the vaccination at that time because the acceptance also is likely to be better. Avoid unnecessarily delays. For example, a patient who is diabetic has to be offered the vaccination for hepatitis B and other vaccinations earlier, because the earlier we vaccinate, even the body is able to generate a better immune response rather than once the patient's condition is more immunocompromised. And before vaccination, Always check the expiry date, as well as the cold storage maintenance has to be recorded for the vaccination. So, as we all know that it is during the whole entire life, the immune system changes, and it develops from the early childhood, and it matures during childhood into adulthood. Subsequently, as the age advances, especially after the age of 50, there is a decline in the immunity, and that is known as immunosenescence, which predisposes to several infections. So, based on the age, there are certain specific infections which are more common, and some infections are more common in a particular age group. So, the vaccinations can be timed accordingly to the age group. For example, vaccination in young adults, the most common hepatitis B and hepatitis A. These two vaccinations can be offered besides HPV vaccine. Less than 15 years of age, HPV vaccination, only 2 doses are required. But if more than 15 years of age group children or adults are arriving to us, then we have to offer them 3 vaccines. So earlier we do it, the number of vaccinations are also less. Chickenpox vaccine, which is known as a varicella vaccine, which can prevent the chickenpox. It is predominantly in the young adults where it's less than 35 years of age, where if suppose chickenpox occurs, it can be very harmful, and it can be very severe with complications. Typhoid vaccination for young adults, because it's young adults who are likely to eat outside and are more at risk for typhoid, which is the salmonella infection and presents with fever. And in fact, it is one of the most common causes of fever which we see in our clinical practice, which also turns out to be blood culture positive. Influenza vaccination in young adults, especially if there is a risk of allergy and allergic rhinitis. These are the in those patients, definitely influenza vaccination should be recommended. Along with this, meningococcal vaccination for prevention of meningitis because of the meningococci. Besides this, in case of pregnancy, the Tdap vaccination, influenza vaccination, which is preferably given during the 3rd trimester, and then we have the Hep B, Hep A, as well as the Hep E vaccine. Hep E is now a new vaccine which has also arrived, and especially when there is a more chances of developing fulminant hepatic failure, this is a vaccine which can be recommended or offered. But particularly, I would suggest that in pregnancy, it is the hepatitis B, hepatitis A, influenza, and the Tdap vaccine. And as live vaccines are contraindicated in case of pregnancy, young women who are likely to become pregnant and are seronegative, they should be vaccinated for the measles, mumps, and rubella, as well as for the varicella before before the infection strikes during pregnancy, where it can be harmful to the mother as well as to the child. Elderly age group who are at a high risk should be, the timing of vaccination is definitely more than 50 years of age for prevention of influenza, PCV20, RZV, Tdap, hepatitis B should be offered to them, especially hepatitis B, because many patients as the age advances may develop chronic kidney disease and may require dialysis, and in such cases um, uh, it is better to vaccinate early so that hepatitis B can be prevented. Certain basic principles and the do's and don'ts related to the vaccine would include that live vaccines are given subcutaneously and killed vaccines are given intramuscular. Live vaccines like the MMR, varicella, and the yellow fever vaccine are not to be given in case of immunocompromised patients and pregnant individuals. Two live vaccines should not be given together. They should be given 4 weeks apart. We can give only two vaccines together. One is on two different sites, that is the deltoid, and one live and one killed vaccine or two killed vaccines can be given together. PCV13 and MCV should be given 4 weeks apart. Hepatitis B, again, besides the timing, it's the position or the site, should never be administered in the gluteal region as it may fail to elicit the immunity. Again, DTaP subcutaneously has more adverse reactions. So this particular vaccine, this is the site has to be taken care for, and we should never mix the vaccines to reduce the needle stick injury. That's also a very important aspect of it. Now, cold storage maintenance is very important. So before we are giving the vaccination, check for the storage, and this can be checked along with this data logger, which can help us in maintaining the record of the temperature that the cold storage has been maintained. Now, when a patient arrives to us in our practice, when we see a patient in the OPD or a patient who is hospitalized, as clinicians, we must ask ourselves that can we prevent infection in this patient? Because prevention is better than cure and prevention is better than hospitalization. So the initial assessment must start with the age as well as with the comorbidities. Elderly patients, patients with chronic diseases like the diabetes, lung diseases, heart diseases, any kidney problem, liver disease, immunocompromising condition, which can be cancer, autoimmune recipients, patients with who are have undergone a transplant or likely to go in for transplant, receiving steroids, patients with rheumatological diseases, rheumatoid arthritis patients, pregnancy and allergy. All these comorbidities should be sought out for, and particularly even simple um, age is important. Adult patients more than 50 years of age, they can be offered prevention against RZV or shingles with the effective Shingrix vaccination. And if the age is less than 50, if a patient is immunocompromised, like a HIV patient or having some other chronic diseases which is decreasing the immune status of the individual, they can also be offered the RZV vaccination for prevention of shingles, because when the immunity declines, there is a decline in the T cell mediated immunity that results in reactivation of the virus and results in this painful um, rash, which is known as shingles. Besides this, we have to look into the habits, which is smoking, alcohol. Again, past history of diseases, which includes whether the patient has had varicella in the past, pneumonia, typhoid, are important. And if these are present, then the patients should be offered effective protection measures. Patients who are likely to have more global travel, they should be offered the influenza vaccination as well as yellow fever vaccine for certain countries. And us analysis of the immune status with the serological test, which includes the anti-hepatitis B antibody, VZV IgG titer, anti-HAV IgG, measles as well as the rubella IgG in case of young adults should be checked for. And if it is negative, then we must or we can offer them the vaccinations as well. Now, it's important to remember that there is no need for the VZV titer or checking the VZV IgG in a normal adult more than 50 years of age just for giving the Shingrix vaccination. This is because most of the patients more than 50 years of age have acquired chickenpox in the past, and that's why it is not it is not necessary to check the VZV titers in such patients in adults more than 50 years of age. Coming to the recommendations of the timing of the vaccination, let's look at this case. This is a 2-month post-renal transplant recipient who's asking about the flu shot. What's correct? Wait for 6 months, give the inactivated influenza vaccine now, give the live intranasal vaccine, or avoid the flu vaccine. Okay, so as this patient is a post-renal transplant recipient, live vaccines are contraindicated. We should give the inactivated influenza vaccine to the patient. However, the recommendation is that in solid organ transplant recipients, post-transplantation, as the immunosuppression is highest during the first 3 months, vaccination is avoided. Vaccination can be started 3 to 6 months later after the transplant once the patient is stabilized, the immunosuppression is lesser, so the vaccination can be offered. At the same time, influenza vaccination can be offered on an individual basis if that is, it can be offered 1 month post-transplantation before the onset of the influenza season, and this can be individualized. Ideally, the best window for the transplant in SOT is the pre-transplant period, where the inactive vaccines should be completed 2 weeks prior and the live vaccination should be completed 4 weeks prior. So if you're suppose giving a varicella vaccine, in that case, the varicella requires 2 doses 4 weeks apart. So we need to start the transfer pre-vaccination 8 weeks, first dose 8 weeks earlier. Coming to the HSCT recipients, in HSCT as well, the timing of vaccination matters and it should be considered after 3 months. So we must wait for at least 3 to 12 months in case of autologous stem cell transplant recipient, and in allogenic at least 6 to 12 months apart, 12 months post HSCT. And what about the live vaccines? So the live vaccines can be administered in the HSCT recipients. However, it should be started 24 months later. So I remember Dr. O.C. Abraham sir mentioning that the HSCT recipient they're like babies and they should be vaccinated all over again. And this can be initiated 2 years post HSCT, provided the patient is not having any GVHD. It's also to remember that when we are offering RZV vaccination to the HSCT recipients, it should be um, started at least 2 months prior to the discontinuation of the prophylactic antivirals, because the maximum immune response of the RZV will occur two months, that is after the second dose. Coming to the biologics and the rituximab, in patients who are taking regular rituximab, the ideal time for vaccination is 4 weeks prior to the next dose of the rituximab. Patients who are having splenic dysfunction, asplenia, then or are planning for an elective splenectomy, in such patients the vaccination ideally should be completed 2 weeks prior. This is because once we vaccinate, the immune response takes around 2 weeks to generate, and then the patient can undergo splenectomy. However, if suppose this is an emergency splenectomy where the prior vaccination cannot be done, then once the patient has overcome that acute stress of surgery and is now stable and is about to get discharged, that's when the patient should be vaccinated. And here the focus is on infections with the capsulated organisms like the Streptococcus pneumoniae with the PCV20, meningococci, and the Haemophilus influenza B. In patients who are having chronic diseases like the diabetes and chronic conditions like the heart disease, liver disease, as well as interstitial lung disease, COPD, in these patients, again, the inactivated vaccines are recommended as early as possible. As the disease advances, the immunosuppression will increase and that may blunt the immune response. So the earlier the better. And live vaccines are also safe and can be recommended based on the age and the requirement of the patient. Coming to steroids. If a patient is on steroids, is it a contraindication for the vaccine? No. If a patient is on low dose steroid, that's not a contraindication. inactive vaccines like the influenza and the other vaccines can be safely administered. Even live vaccines are safe. However, if the patient is on high dose steroids, which includes more than 20 milligrams per day for more than 2 weeks, then inactive vaccine can be given. But if the patient is taking steroids and we are anticipating that the steroids will be reduced, it's better to delay the vaccination till the immunosuppression is also at a lower level, so that when the immunosuppression is less and if we vaccinate, the immune response can be stronger. In case of pregnancy, inactive vaccines should be given, especially the flu vaccine ideally should be given during the third trimester so that it can provide protection to the mother as well as to the baby. And all live vaccines are contraindicated. For HIV patients, inactive vaccines can be given. Live vaccines are not recommended, especially if the patient has a severe degree of immune suppression with very low CD4 count and a very high viral load. Now, when should we vaccinate? Timing of vaccination in HIV patients. So once the patient arrives and we have started the patient on antiretroviral therapy, the initiation, the immune response becomes better when the ART starts acting. It decreases the viral load at and increases the immune um, immune cells or immunity. And once this happens, maybe after usually 15 days or so, the patient has also stabilized and the vaccinations can be offered. So, in HIV patients, usually in my practice, I start with the ART and then maybe after 15 days, once the patient is stabilized on the ART, we offer the vaccinations for further prevention of infections which are likely. Ideally, of course, like viral load should be undetectable, but it is not necessary to wait for the viral load to become undetectable and delay the vaccination. So vaccination should be considered even earlier. So the vaccination timing and the sequence can be modified based on the need for vaccination. If a patient has a high risk of infection, then those vaccines should be offered first to the patient. For example, a patient who has a respiratory disease with ILD, bronchial asthma, COPD, or allergy, then these are the patients who are at a high risk for lung infections. So influenza vaccine as well as the PCV20 for prevention of strep pneumoniae should be offered first, and then subsequently we can offer the RZB vaccine and the other vaccinations. However, in a patient who is an elderly um, patient who have got diabetes, in these patients we can give them the offer of influenza along with RZV or PCV20 based on the affordability. In patients who are HIV positive, here again, it's HPV vaccination which is very important. So, hepatitis B, HPV, and then subsequently, based on the risk of infections, influenza, RZV, PCV, and HAV. In fact, in my practice, I do offer shingles vaccination because HIV patients, because of the low immunity, are at a higher risk for the shingles, and hence, if offered earlier, it can help in the protection against the painful viral infection. Many times we will also experience that patients have vaccine hesitancy and not willing to take up the vaccines. So there are certain low-hanging fruits which can be considered, and that includes hepatitis B vaccination because hepatitis B is a cost-effective vaccine and it is also a part of the national immunization schedule which is given to the children. So it is a safe vaccine. Besides the other vaccines which can be offered is the influenza, because influenza vaccine across ages, across adults, young adults, pregnancy, or elderly patients or patients with comorbidities, even if we are able to prevent one single infection, and that can prevent almost 5 to 7 days of the work loss, and also prevent the popping up of antibiotics and protect us or prevent the antimicrobial resistance. Now let's come to the timing of specific vaccines. The best time to vaccinate against the influenza in India is April to June, August to September, September to October, or individualized. So the best answer is that it has to be individualized depending upon the influenza peak. For maximum effectiveness, the influenza vaccine should be administered before the influenza viruses begin to spread. That is before the influenza peak. And the influenza peaks are across India in different seasons. In the North India, it is around the monsoons. There is a monsoon associated peak which we see in Delhi, Lucknow, Pune, as well as in the Kolkata. And this is around July to September. So the best time to vaccinate in these regions is around April to June, and this also aligns with the availability of the new vaccine, which is usually available in April. However, in cities like Chennai and Vellore, there is a late monsoon peak with peak in October and November. So the best time to vaccinate is in August and September. And in the northern part of the country, like the Srinagar, which is a temperate region, the influenza is peaking around December and Feb during the cold winter, and that's why the best time to vaccinate here is in September. So the timing of vaccination will depend upon which region the patient is from, and in that region, what are the influenza peaks which are being observed. Another patient who is a 67-year-old lady who is having allergies, and she's also having recurrent LRTI. She has received PCV13 a year back. Now, what is the next step? Should we give no vaccine? Give her the polysaccharide vaccine? Give her PCV20 now, and no PPV23 is needed. Give her PPV20 now, and then give PPV23 1 year later. So this is one of the latest recommendations, and if a patient has received PCV13 a year back, then PCV20 can be administered to the patient for offering a better protection. We all have seen the cost effectiveness of the conjugate vaccine in Indian adults more than 60 years of age, and definitely use of conjugate vaccine PCV13 has shown to reduce the healthcare cost and is associated with prevention of illnesses. This is the API guidelines and the recommendation for the pneumococcal vaccination. As we can see, it's PCV20, which is recommended for all adults. So everybody more than 50 years of age, people who are at risk or at a high risk, which includes all these conditions, single dose of PCV20 is sufficient for the lifetime. And why is this? This is because earlier, the sequential vaccination was recommended, and the premise was that PCV13 provides protection against 13 common serotypes, and PPV23 would provide protection against 23 common serotypes. So, for the additional protection against the other serotypes which are causing pneumonia, sequential vaccination was being recommended. But now, with the availability of the PCV20, which provides protection against 20 serotypes, this sequential vaccination is not recommended, and it is a single shot of PCV20 for all adults with chronic conditions, immunocompetent individuals, immunosuppressed individuals, and even in adults with very high risk of strep pneumonia, like patients with cochlear implants, CSF leak, or even splenic dysfunction. Single dose of PCV20 intramuscular is recommended for prevention against Streptococcus pneumonia, as well as the invasive diseases. Let's move on to shingles and its prevention. This is a 50-year-old lady who had developed the severe shingles on the face. So in this lady, when should RZV, which is the shingles vaccine, Shingrix vaccination, should be given? So there is no need for vaccination as she has already had shingles. RZV should be offered once the lesions have healed, 2 months later, or 1 year later. So the correct answer is that shingles itself definitely boosts the immunity, but it's not reliable. And once the acute phase is over, the vaccination timed right prevents the recurrences and the PHN. So the risk of shingles recurrence is not very high, it's 1 to 5%. But people who have had shingles, they will accept that it's a very painful condition, and that's why prevention is always better, and they can be well, this can be done. Now, timing has to be, so there are several recommendations related to this. So as per the CDC, there is no specific length of time that you need to wait after having shingles before you can receive the Shingrix vaccination. And generally, just make sure that the rat has gone away before getting vaccinated. However, there are other guidelines from the National Centre of Immunization and Research in Australia which are more conservative, and they mention that a person who's already had shingles, they can receive the shingles vaccine. However, in an immunocompetent patient, they can wait for at least 12 months. However, if the patient is immunocompromised, as the risk of shingles is more, they can receive the vaccination 3 months after the episode of shingles. So I think we need to individualize it. In an immunocompetent individual, once the lesions heal, the vaccination can be offered. In an immunocompromised patient, immunosuppressed patient, based on the level of immunosuppression, we can gauge that when should we time it right so that even the immune response with the RZV vaccination is maximum. So here I think it's 3 months would be the ideal time to provide the or offer the vaccination. In case of solid organ transplant recipients, regardless of the VZV serological status, vaccination, or even clinical infection status, the SOP candidates as well as the recipient should all be vaccinated for the herpes zoster. Complement deficiency like the ravulizumab or eculizumab is not an indication for giving the RZV vaccination. In immunocompromised patients, an accelerated schedule. So normally we give 2 doses, 0 to 2 to 6 months apart. However, in immunocompromised patient, 2 doses, 0 and 4 to 8 weeks can be offered. The vaccine efficacy does not really differ if it has been offered at 0 to 2 months or 0 to 6 months. These two strategies have revealed identical antibody levels. And the duration of protection with the RZV vaccination has been more than 10 years in the clinical studies. Now let's move on to hepatitis B. This is a 48-year-old patient who is having CLD and is planned for the liver transplant. He is hepatitis B negative. His antibody titer is less than 10. What next? Start the 3-dose hepatitis B series at 0, 1 and 6. Wait till the post-transplant period. Give single booster dose only. None of the above. So now in this patient, of course, we should not wait for the transplant. If the patient has not had any prior history of hepatitis B vaccination, 3-dose hepatitis B series should be offered. But as he is about to go in for transplant, an accelerated hepatitis B schedule of 0-7-21 pre-transplant can be offered to the patient. And if a patient is a dialysis patient, then double dose 40 micrograms of the hepatitis B should be offered. Now, this should also be considered if the donor is hepatitis C antibody positive. So if this is positive, then also especially the accelerated schedule should be offered. The timing of vaccination is not just important for the patient who's at the core, but also for the caregivers as well as the family members. And all these vaccinations, which includes the influenza, pneumococcal, hepatitis B, varicella, zoster, that is the RZV, and Tdap vaccination should be offered to the family members so that once they are protected, they will also protect the patient. It's important to remember that caregivers or the contacts should receive or should avoid the live vaccines 4 weeks prior to the transplant. So they should be completing the entire course 4 weeks before the patient is likely to become immunosuppressed. So to summarize, it's important to definitely vaccinate. An ounce of prevention is worth a pound of cure. And this is a very famous quote from Ben Franklin. And this is me vaccinating my father. And we've also vaccinated my mother recently again with the influenza, the annual shot of influenza along with the PCV20. And this is a famous quote from Dr. B.R. Subramanian sir, who says that, of course, knowing is not enough, we must apply. Willing is not enough, we must do it. So we must always practice what we know, and that is vaccination. Not just it's vaccination that saves lives and not just vaccines. Thank you so much.